So acromioclavicular joint, understanding the joint is important. This is what it looks like. This is what it has around it. So it's a synovial plane joint. It used to be called as diarthrodial joint. However, we moved on from that and we call it a multi-axial joint. It has two convex surfaces which are covered with fibrocartilage. And in some patients, you might find a meniscal homologue. Now, that's a little disc that is there in between. It connects the superior and the inferior capsule. It can be a source of pain when the joint looks normal and we can't find a source. So an MRI would help you find this. So a fibrous capsule, superiorly the capsule is a lot thicker as compared to the inferior capsule. It has the acromioclavicular ligaments as a part of the superior capsule. Extrinsic ligaments are the coracoclavicular ligaments, and they will hold on to the clavicle whilst the acromioclavicular ligament holds on to the acromion. Forces or the motions that the AC joint goes through is protraction, retraction. It goes through elevation, depression. It also rotates. So there is an axial rotation along the line of the clavicle. So what pathologies do we look for in acromioclavicular joint? So common ones, acromioclavicular joint injuries which result into separations, or the AC joint separations. There are 6 categories, I'll come to it. Lateral end clavicular fractures. We get arthritis of the acromioclavicular joint, and we also get os acromiale. Now there are other few pathologies related to the meniscal homologue. I'm not going to dwell into the details of that. So let's go to the first one, which is the most important one and we see most often, which is the AC joint separation. This is a Rockwood classification of the AC joint separation. It's got 6 categories. The first 2 categories is a partial injury to the capsule. The third category is 100% injury to the capsule, but it is a reducible or a non-reducible pathology depending upon which kind of grade 3 you see. Grade 4, 5, 6 are associated with coracoclavicular ligaments injuries with it and displacement of the clavicle. So why do we need to know this? Because type 1 and type 2 can very well be treated conservatively without any problems, most often than not. However, it is not that they are without problems at all times. So there are failures of grade 1, grade 2, and you would often see that the patient comes across, you see it's a grade 1 or grade 2, the patient still complains of pain, you don't know what to do about it. The reason is there is residual instability. Yes, there is a 50% injury, but still it can be a source of pain. Treatment for that is generally an injection, and that works. So think about it next time when you see somebody with grade 1, grade 2 and they've got pain and we still think that actually, you know what, we can't operate on this. So what do? Patient still complains of pain. Type 3 separations is the biggest controversy currently we have in our literature. To simplify this, I would probably say try and reduce the acromioclavicular joint. If you see a type 3, if it is reducible, it can be conserved. If it is not reducible, I think you're going to fail conservative. So just keep it that way. Type 4, type 5, type 6, these are severe injuries. They more often than not require a surgical treatment unless you cannot treat the patient immediately. Because of the severity of the injury, you often find associated injuries with these kind of fracture. So look out for them. Treatment for AC separations. This is or where historical treatments. We used to use screws, wires, commonly known as the Bosworth screw, and wires to assist your Bosworth screw to hold it. However, often failed because we underestimated the force that goes through the acromioclavicular area or the coracoclavicular area. We would end up doing a Mumford procedure then because the lateral end of the clavicle hurts. Modern treatment, we have started using either synthetic material to bring back the acromioclavicular joint, or we can use biological, which is a semi-T or a fascia lata or a gracilis graft to bring the acromioclavicular joint back. All we're doing is we're trying to reconstruct the coracoclavicular ligaments, which is the conoid and the trapezoid. So I'll go to a straightforward case of an acromioclavicular joint, 20-year-old male, right hand dominant, falls off a bike on the right shoulder, direct contact, has a grade 5 acromioclavicular joint separation. It is acute. It's come within the first 3 weeks. So we operate because it's a grade 5. That is what it looks like when they are in a beach chair position. That is how I operate. You can see it pinging up. It is non-reducible. And I often use a C-arm just to be certain where I'm putting my buttons. I do them arthroscopically. So this is a short video of arthroscopy. So we've got an anterior portal. What you see in front is a subscap. We're mobilizing the anterior capsule and the tissues around the anterior capsule. The wand works really well in this kind of situation because it is your dissector and it is a curator. So it can control the bleeding if there is any, as this area is reasonably vascular. At the same time, using the wand helps you separate the tissue from the capsule. The idea is to gently dissect the front of the shoulder so that you can reach the base of the coracoid. Okay, so what you've got is now the base of the coracoid, and then you just gently dissect, because we know on the medial side of the coracoid we have the clockwork. So we have to be very gentle, very careful. We are at the posterior side of the coracoid, so this part is reasonably well preserved from any nerves or vessels, so you can gently keep dissecting medially on this side, and then you have to create portals to help you deal with the entirety of the coracoid. So now you viewing from another anterior portal and you're going underneath the coracoid. So once you gently start dissecting the undersurface of the coracoid, you try and see the base of the coracoid. Base of the coracoid is where you will see a flare. The base of the coracoid is the best part of the coracoid bone. So whatever fixation you want to have, you want to try and be as close to the base as possible. Sometimes it's difficult, but not impossible to go very close to the base. You can then try using jigs. There are designed jigs to pass a tunnel from the clavicle to the acromion, and the guide wires are cannulated. Okay, so you've got a cannulated guide wire, and then you pass a nitinol wire through that cannulated guide wire, and you retrieve that cannulated guide wire from your anterior portal. And you see a retriever coming in. You can see, you can appreciate the coracoid and you can appreciate where the base is. And a guide wire comes out, the endo button or a dog button, whatever button you like, with a fiber loop gets passed through the drill that has made the tunnel for you. The dog button or the endo button, however, has to be gently eased for it to sit where you want to sit, because you've got tissues that you're using to circumvent before you use the base. It's often advised to use a grasper to gently sit the dog button under the base of the coracoid. You can at this moment choose to resect the lateral end of the clavicle, or you can choose to leave it. I generally leave it because I generally find a very good reduction. So the literature says you should excise it. I have not had a problem. That's why I do that. And that is what it looks like. That's an X-ray that I took intra-op just to ascertain that my dog button is bang in the center of the coracoid. And you can see the reduction. There is a button on the top of the clavicle. That is the patient post-op. That is the patient after a year. So it works brilliant. The only caveat is it has to be done acute. You can't do this chronic. Do not even bother attempting it chronic. Otherwise, the hole you will create will not be filled because you will not have a coracoid. So we've had multiple studies that says chronic problems require proper reconstruction rather than, this is a soft reconstruction because you are relying on the native coracoid and the trapezoid ligaments to heal. That is why acute. Coming on to the lateral end of the clavicle, so I'm going to show the one that is the most difficult of this. So 6 types or 5 types, type 2 divided into 2 types. Type 1, conservative. Type 2, A and B, definitely surgical. Type 3, conservative. 4 and 5, surgical based on how you feel and what the patient is about. 5 is definitely surgical because everything is off. So I'm going to show you a case, a case of type 5, and to complicate it more, in a non-union. So the reason why we talk about lateral ends and why we want to fix them or be aggressive about them is because the non-union rate is anywhere between 10 to 12% as compared to a mid-shaft where the non-union rate is about 1.5 to 2.5%. So we are really looking at 5 times more non-union rate. So that is the case. A 38-year-old male comes with that. Right hand dominant. Falls off a bike 5 years ago. Was treated conservatively for 5 years. The reason he's come, he has got pain in the shoulder, he's got restricted range of movements, and he cannot get power in overhead activities. So how did we treat it? So we used a combination of a Mercilin tape with a fiber wire tape. Okay. So I generally interweave the Mercilin with the fiber wire because we do not have eponymous artificial ligaments available in the country, which is easily available abroad. So to match that strength, you need the strength of the fiber wire and the Mercilin tape. Mercilin tapes is easy, cheaper, and often we find these patients are not affording. So that this is a combination that I feel works well in my hands. The approach is, it's a beach chair position. It's like a saber cut on the lateral end of the clavicle. Dissection, the Mercilin tape with the fiber wire is passed under the coracoid, brought up, tunnels are drilled in the clavicle, and then a button is used to tie the clavicle or the tapes onto the clavicle to reduce the distance. Now the problem with this is obviously that we also have to deal with a non-union. So we harvested some iliac crest bone graft because that was what it was when it was reduced. We still have to fill the gap. So we used a modified technique whereby we have harvested an iliac crest bone graft, put it in between, freshened the lateral end of the clavicle, and passed the remnants of our fiber wire through the lateral end of the clavicle and the bone graft so that it does not move. And this is what we get. This is the patient post-op. I don't have his year follow-up, but I think at 6 months follow-up his graft had healed. His graft lateral end had not fully healed. So what effectively happened was that type 5 was converted to type 1. So he was still functional, he was doing everything. And as you know, Once they are functional, they don't come to us and show us how good they are. So this is the last case, 53-year-old male. That is what you get. It's a Bandor, ACJ arthritis, right hand dominant, left ACJ pain, restricted overhead activities. What do you do for them? Straightforward arthroscopic ACJ excision. And again, it's a straightforward procedure. You can see that the clavicle is moving, the ones under the acromion or the acromio clavicular joint, and you're just opening the joint from under the surface, because the inferior acromio clavicular ligament is the weaker of the two acromio clavicular ligament, and it reforms because it can reform with an element of scar tissue. So you can afford to sacrifice it to excise the clavicle or the lateral end of the clavicle and hope that it will reform. So then, to excise it, you need a bang anterior portal. And you can see the trocar coming in so that we can use our burr in that direction to cut the lateral end of the clavicle along with the lateral end of the acromion. And we start with the lateral end of the medial end of the acromion, and we make that convex into a slant so that our vision is better for the lateral end of the clavicle. And it's a process because this bone is really, really tough. So you have to be patient. You have to just keep going. No matter how old the patient is, I've always find that the lateral end of the clavicle in arthritis is quite difficult to fully excise. Now I use the burr as my marker of how much to excise, and the general is that your burr should be easily in and out of the space that you create. The burr's girth or the diameter is a 5.5 millimeter. In an open excision, we take about 5 to 6 millimeters of the lateral end of the clavicle. So in an arthroscopic excision, if our burr can go in easily, then we've removed about 5.5 millimeters of clavicle. And the other important thing you'll see is that the posteromedial border of the lateral end is the most difficult to get to, and this is what I am identifying right now. So that's the posteromedial border, and you can see that despite the clavicle looking reasonably excised, it is not actually excised, and you have to excise a little more. So this is what the patient is at 3 months. So in summary, AC joint separation, grade 1, grade 2, conservative management, grade 3, conservative operative based on the patient, grade 4, 5, 6, definitely surgical management. 5 is the commonest. AC joint separation, acute separation, arthroscopic ACJ reconstruction is a very well respected and proven technique. Chronic separations and open ACJ reconstruction is better than an arthroscopic. ACJ arthritis is arthroscopic excision.